Good afternoon, everyone. My name is Stuart Blackwood. I'm a board-certified vascular surgeon who is on a mission to bring easy to understand education to people looking to better understand everyday problems that affect the vasculature and the vascular system. As a practicing vascular surgeon in the United States, I understand all too well how hard it is to get time with your healthcare providers, and many of the time our questions are left unanswered as patients. Our goal at Blackwood Vascular is to focus on creating a space for those questions. We will focus on education, not medical advice. This should not be considered to be medical advice in any way, and any medical decisions that you should discuss with your actual vascular surgeon who is in your community and who cares for you, or your primary care provider or other specialists. So let's get into it. Today's topic is renal artery infarct. And this is an interesting case where a patient who was elderly presented to the emergency room with abdominal pain, which started really a couple of weeks ago and ultimately led to them having belly surgery. Post-operatively, everything seemed okay. Patient represented and ended up with a CAT scan with IV contrast, which highlights the reasoning why we should have IV contrast more often in the emergency room. But nonetheless, it's essentially that person showed up with this area of narrowing and blockage. When they did the CAT scan, what they identified was a artery. I'm going to draw the picture of the aorta here now. So if you're following along, you'll see that I'm drawing this on the screen. This is the aorta, the main blood vessel coming down. Here is an artery that goes off to the right and the left kidney. And in this case, patient has multiple arteries that go to the left kidney. Here's the left kidney right here. And the arteries continue down. Here's an intestinal blood vessel. Comes off there, but we call that one the celiac. Feeds the stomach and the intestines. And the superior mesenteric artery feeds we also call it the SMA, superior mesenteric artery. Essentially, this feeds these two vessels, the celiac and superior mesenteric arteries, feed the intestines, whereas the kidney arteries, here is a kidney artery here, here's a kidney artery here, 2, here's a kidney artery number 3 right there. In this case, the person's heart has a condition called AFib. And AFib basically means that the heart is just sort of fibrillating instead of making nice, strong contractions. What happens is when it just has this fibrillation effect, you can imagine that blood kind of becomes stagnant in these little pockets. As a result of that, when the heart does make a good contraction, or just every so often randomly, a piece of clot that might become formed in that little pocket might break off and travel down, which is what happened in this patient's case. Let's just pretend that this is all the blood vessel here. So this clot breaks off and travels downstream this direction towards the legs, but instead of going into the leg, it goes into this kidney artery and plugged the entire kidney artery up. Now, the kidney is an organ where they don't have a lot of connection points, what we call collaterals. So as a result, this entire portion of the kidney became non-functional. And with that, the kidney became swollen and engorged and painful. The person noted that they were having belly pain. Some people, when the most common symptoms that people will have is either flank pain, which is not true belly pain, but on the flank, like on the back almost. People say you've been punched in the kidney. kind of back there. That's where most people have their belly pain. Other people will have just general symptoms which are non-specific, like nausea, vomiting. Sometimes, rarely, you can notice blood in your urine. And if you go to the ER and the emergency room doc is checking you out, then they might notice that your kidney functions, your creatinine has risen. And so those numbers are what we usually use to make the decision. Now, they called on me, the vascular surgeon, to essentially see the patient and see if I would consider revascularizing, meaning reopening the blood vessels to the kidney. Now, many times, if you called on me and this blockage was in the superior mesenteric artery affecting the intestines, I would go straight to the operating room usually and try to get this blockage out. The fresh clot sitting in the SMA, you got to fix it immediately. Now, the problem that we've found is over the years is that the science is not very good on when to open up a kidney artery after a clot. In fact, the best cases are when you have a fresh clot, meaning very, very soon after, meaning within hours, the person develops a clot, even in the hospital. Let's say a patient who is hospitalized and develops a clot right afterwards in the hospital, and you made the diagnosis quickly. These are a lot of things that have to happen quickly. We know this from evidence with patients who have stents, which we place in the kidney arteries for different reasons. And in those patients, we might have them in the hospital a couple of days afterwards for a complicated operation, and the artery might block itself off and the kidney might not have any blood flow whatsoever. And in that situation, we go back, we rescue the kidney, and we can regain function of that kidney. But for most patients, unfortunately, who have kidney blockages from AFib, they're at home, they started to have some nausea, some non-specific, who is really going to show up to the emergency room in 2025 immediately for some nausea? So it just, unfortunately, by the time they usually get to the emergency room, 6 hours, 12 hours, 24 hours, more days sometimes have passed. And in this patient's case, I suspect that the patient's symptoms actually started many, many days before she was referred in. So she showed up with this flank pain. They actually got a CAT scan with IV contrast, a very useful study. Picked up the clot in the inferior pole of her kidney, and they called me very immediately afterwards, after they got the results from the CAT scan. I immediately called in. This was at the referring hospital, and I offered to take care of the patient. Unfortunately, I did give them my advice that I do not think that I'll be able to help this patient with any surgical procedures. And the surgical procedures would be something like a renal artery bypass or a thrombectomy, meaning pulling clots from the actual kidney artery. In this case, this is only a part of her kidney that's affected. This is not 100%, it's not even 50%. In this case, the clots have been sitting there for at least a day, if not more. And I think it's more like a week, if I'm to guess correctly. So I do not think that there's a lot of kidney to salvage, because whatever was injured is probably ischemic or losing blood flow and dead by this point. And if you did open it up, you might return back a small proportion of the kidney cells back to function, but probably not enough to put someone through the risk of a procedure. What else can we talk about? I think probably the big teaching point with this case is, again, the basic teaching point of atrial fibrillation, which is that atrial fibrillation, the heart making that funny kind of coordinated contraction, leads to clot formation, and these people should preferentially be on a blood thinner. Not aspirin, not Plavix. I'm talking about a real blood thinner like Coumadin or Eliquis or Xarelto or one of the other non-novel oral anticoagulant drugs. So there are many anticoagulants available. Some are more expensive, some are cheaper, but they all have risks and benefits, and you can talk to your physicians about that. But the point is that AFib patients should be on some sort of anticoagulant therapy. So how would I treat this? Let's move on to treatment of this. The main way I think to treat this would, in nowadays at least, is a minimal invasive approach coming from the leg arteries. So if this is the arteries, right here you have the arteries of the leg. Here is the groin. Here's the groin here. I would put a catheter in, and just put it in blue right here, and travel up with a wire up in, and put a wire through and past the blockage, and then slide a catheter, which I'm going to put in as green, or actually why don't we put it in as yellow. We'd slide a catheter over this wire. Once we are in the position, we'd slide this catheter all the way up, and the catheter would have an open internal port. So you can imagine the catheter has like a little opening here, and you can suction this clot right in, right this way, and suck it back out. So that's an easy way, that's minimal invasive, and at the end of the procedure, the patient only notices a small little puncture in the groin. You pull out the catheters at the end, you hold pressure, the patient lays 4 to 6 hours after some sort of closure device or just standard manual pressure is held, and they get discharged home. When do we do this? When would I do this? If the patient came in with a fresh kidney clot, or they were in the hospital and they have a new kidney clot within a few hours, I would be I'd be very, very hard pressed to actually move forward and get that kidney clot out as quickly as possible. If the person all of a sudden dropped all of their urine output altogether and had no urine because of clots in multiple kidneys, I would make an attempt to suction out some of this clot, especially if it was, again, in a fresh case. Cases that are 2 weeks old, 3 weeks old, I don't think there is really any significant indication to go after those chronic cases. You can go in and stent and do more chronic related procedures, but I don't think that's not what we're talking about today. Today we're talking about the fresh clot in a kidney. If the person had a single kidney and the single kidney was clotted, or both kidneys clotted with significant blockages, then those are the cases to go forward and get it treated. I think it's important to make sure that you go to a hospital where they have the capabilities to take care of you post-operatively. You need to have a kidney doctor around. You need to have an ICU in some of the cases, not in all cases. But and it doesn't mean that you necessarily need to get all the treatment at the big hospital, but you should get somewhere quickly where they have an interventionalist or a specialist. In this case, a interventional radiologist who is comfortable with doing these procedures, or interventional cardiologist who is comfortable, even a general surgeon who is trained in wire techniques and manipulations might be a good option. If you're in none of those places, and of course this is about vascular surgery, so the ideal position in my place is ideal place in my opinion is a place where there's a trained vascular surgeon. But if you have none of those, I would say you could even get an open surgery if you're young and healthy and willing and able to undergo an open surgical operation. But for the vast majority of people nowadays in 2025, this is a simple procedure if done with a wire and a catheter. I think that's it for today. I will see you guys again next week for another episode. Thank you very much. And again, remember, please go ahead and subscribe if you like this video. Check me out at my website, and in the future we'll be doing live streams and other direct, more curated content as you guys request. Thank you.